talking about analytics. Let's go into that a little bit. So for John and John down at the end there, we talk about analytics. How are you two using analytics at the employer space to validate the return on investment that the employers that you, and Clint, you can chime in here, that the three of you are working with to show that there are better outcomes for employers and the employees in the employer model?
Well, I mean, what you have to understand is we actually do believe wholeheartedly in DPC. We care all about patient navigation. We understand the relationship between the physician and the patient is exactly what we're all wired to be, right? So we're heavy on cultural connectivity with our groups. And so there's a lot of education and things that go into that process. There's hand-holding and there's a really touch and a big feel component of what we have to deliver, and education and making sure those engagements are happening on a recurring basis is all part of how we have to deliver this service. Technology, to some degree, is the only thing we have now that can help validate and provide the evidence that what we're doing is uniquely special and different in driving the outcomes that we're all after, right? And so we go back and understand that, we have clients today that if they don't get some level of input and reporting that's coming back to them through the form of a feedback loop, they're going to disconnect to some degree without that validation. And so a key element that we try to focus and we're really trying to do is make sure that on a monthly basis and create like a pattern, an operating protocol, if you will, that the clients then connect onto and they're gravitating towards, and validating the model. Also, it's all about health improvement, the outcomes, but also ROI. I hate to say it, a lot of, especially larger employers, ROI is a calculation that we have to bring back to them. Smaller groups, the less than 50s, they actually do see this as a benefit, and they're maybe okay not getting all that recurring information flow coming back their way. And they're probably really easy for most of us to navigate and manage those relationships. But those larger employers, there's some amount of overhead associated with that. So technology is needed, partnerships with a lot of the tech firms that are here with us today, and making sure that we have a collaboration and pulling data and understanding how that data impacts our care delivery process. Total cost of care analysis, I have to say, is extremely important. Because you cannot take a fee-for-service primary care physician that charges, that's some subcomponent of their total cost of care and compare that against us. You can't really do that because there's not a direct correlation as to how a fee-for-service and what their costs and reimbursements are. It's completely night and day different as to how we deliver our services and how much more. So you mentioned 1.2 visits, I believe. We're exceeding 5 per year on an annualized basis. Our goal is to get to 8 per year on an annualized basis as far as utilization. Data is helping us figure out what it takes to improve these measures, and employers need that communication and feedback to validate it.
Which measures are you giving employers? Clinical measures?
Clinical measures, not quite as, so the clinical measures, right? So we have, things around physician, navigation of care is a big part of it. Gaps in care analysis is a big part of it. Understanding your high claimant analysis is a big part of it. Plan design, optimization of plan designs. They need to get a better understanding of what the optimization of those plans are. Should we go from a fully insured to a self-insured, or maybe that middle ground of a level plan option? Can you help us on a pathway as a care provider to start helping us make those decisions along that path? And can we maybe come in on the front end of some of this stuff to help prepare them for some of these evolutionary changes? We really don't like fully insured products, so we want, most of our employer groups greasing the skids, if you will, to help them move from a fully insured product to other, more products that we could then drive better savings around and produce better results.
So, from the large employer side, this is a huge investment, huge upfront investment for them. So, proof's in the pudding, and data is the tool that we use to prove it, just like John was saying. But on the flip side of that, data is a weapon, and it's a weapon that physicians can use. Specifically on the self-funded side, self-insured side of things, that's their data. The employer owns that data. And so we have software and analytics that allows us to look at those claims, allows us to do, 36 months, before we ever come in, we know that population really well because we've looked at the last 3 years of those claims, and we aggregate it to biometrics. And then going forward, on a real-time basis, monthly, we're getting feeds of these claims. And so our physicians are able to look at that, and when Mr. Smith walks in, we can see how much Mr. Smith, the plan is paying for them. We can see how he's using this network as a consumer. And we can really help educate that Mr. Smith to be a better consumer of healthcare. Say, Mr. Smith, you went to the ER. Call me. I'm available to you after hours. I want to help you. As far as clinical measures that employers ask for. So large employers, and their benefits consultants, they still think in terms of things like HEDIS measures and things like that. And I know that's probably a bad word to even say here, but I'm with you guys. But they think in that. And so it's important, if you're going to compete in this employer space, to come up with some type of solution that still can show national benchmarks, that can show as close as we can, just like John was saying. There's not going to be an apples-to-apples comparison of this DPC model versus any other model that's out there. But we want to get as close as we can and give, this movement's about transparency. And so if we want to truly be transparent, we got to show that data. And if we want the employer to be transparent with us, we got to take their data as well.
I would just add to that, the way that you best improve your data is access. So you can have all kinds of fancy tech tools, et cetera, to try to manipulate and change your data and this and that and the other, and you can have biases, but the best way to improve your data as an employer group is access. Commonwealth Foundation, I believe, had a study in 2013 that says that if you have a primary care provider, you're going to decrease your spend for that patient and or employer group by 33%. And the interesting thing there, that was a study of mainly fee-for-service docs. So if you have a primary care provider, I prefer the term physician, if you have that DPC physician fronting your plan, and you're going to have crazy access, you're going to have all kinds of awesome data. And so that's where we want to rely upon tech to help us prove that, right? Because what do we want to get away from? We're running away from pecking for payment. It was Garrison that mentioned that to me a long time ago, and it sticks in my brain because I still peck for payment on a daily basis. So how can we get as few keystrokes as possible to show our value? And we know we provide a ton of value, but we just don't want to spend half of our day, which is a recent study, I think it was published in Forbes, pecking for payment. So we rely upon tech, and that's part of what I think Hint's building here is few keystrokes as possible, and or having your MA keystroke for you, and then showing decreased urgent care visits, decreased ER visits, decreased elective imaging, decreased elective surgeries. But to John's point here, some of these larger employer groups, when they're writing you a large check every month, they can say things like, I want to know how many times our employees are texting you. How many times are employees calling you? What have you done to engage them? And then you have to show that, right? So that's where you have some tools, Spruce, Hail, et cetera, to help along that pathway. So if you are targeting the larger employer groups, the demand will be greater. Smaller guys, like John's plumbing company, they could care less about all that stuff. That's the beauty. I love those guys. But their checks are different that they write to.
Yeah. For some of when you guys approach potential employers, what have been some of the things that maybe those data points? What are some of those data points or analyses when somebody does care about those numbers? What are some things that you share with them in order to kind of appease their ROI that they're looking for?
You want me to cover that?
You get on the
So we do something similar. So 2-3 years worth of historical data is usually where we start as well. One of the key elements is to understand their enrollment information, so their cycles associated with new enrollees, their add new delete information. High claimant analysis is a big part of that, at getting in front of it. Chronic diseases, we get a decent understanding of where those disease states are. Their pharmaceutical information and pharmaceutical claims data is a key element to that as well. And there's a fair amount of patterns, referral patterns and some other things that we look at that help us evaluate whether or not solutions like maybe a narrow network, not for all, but every once in a while, maybe some narrow network options are a way to go to drive some discounting because of the type of population that you actually have and that you're serving. So once you get that front-end information, you really could start refining the types of things that you're doing and how you're managing that population. And you're going to want to hold yourself accountable for that. It's not just the other way where the employers are, now it's almost like this self-accountability thing. We want to measure how well we're doing for our population. That's a part of why data is important to us. And it's a very cool thing to feel when we actually bring that information flow and we're educating a client about that, and then we're in a meeting, because we hold regular meetings with our customers, and when it's not just the data element, but when you're telling the stories about what's happening on our mobile unit, a 40-foot RV that we're putting into the community to help our special needs patients, there's an incredible amount of data off of that. But more importantly, the tears that come in those sessions when we're meeting with employers, and a board member or a director on the board is sitting there saying, I cannot believe this is what we're doing to impact our community specifically for special needs. The data is the data. It's great. It's fine. Validation, great. It makes us feel good about what we're doing. But in the meantime, it's those tears when we're sitting in meetings that I believe are the most special part of it.
And what I would add to that is part of this too, guys, is the physicians is we're keystroking it, right? We don't have to produce the fancy report. We need to have the tech tools that as we keystroke, send to someone else that has the bandwidth and the expertise to produce the fancy report. And that's part of where the broker comes in. So we work with brokers, Hub International is an example. So we keystroke, put the data in, sends to them, and they analyze. So there's a variety of ways to do that, I think, but in these self-funded groups, you'll find that you can rely upon your brokers, which have years of expertise in this arena, to help produce those reports. And plus, the beauty with that is you now have kind of it's not biased, right? Because if you're trying to make all that fancy data yourself, and you're getting a check every month, there could potentially be some internal bias. So you put data in, send to others, they analyze and produce reports. And by the way, that's what, to a certain extent, brokers for these large employer groups are kind of paid for.